Hello, I'm Dr. Marla Shapiro, and I sit on the Board of Trustees of the International Menopause Society. Today, we're going to be talking about a very complex subject called polycystic ovarian syndrome. And for that, I'm joined by our world expert, Professor Fauser. Hello and welcome. And can you tell our audience a little bit about you?
Hello to all of you. My name is Bart Fauser. I'm a professor emeritus of the University of Utrecht in the Netherlands. I'm an obstetrician and gynecologist with a long history in reproductive science. And one of my particular areas of interest since the very, very beginning is women that suffer from polycystic ovary syndrome.
So as a woman, I've heard that phrase PCOS, which is what it's abbreviated, but what are the things that I should look out for that might tell me that I might have this syndrome?
Yeah, the term PCOS is debated a lot. Is this what we really want at this stage? And not just we as doctors, but certainly also the women involved. And this is an ongoing debate already for a long, long time. It replaced the term Stein-Leventhal syndrome. That's how it was originally coined by the two quote unquote inventors, Mr. Stein and Leventhal, and that was based on ovarian morphology. So in the early days, you need to do biopsies of the ovaries to be diagnosed. Then it went
But I, as a woman, what symptoms might I have that might make me think, oh, I might have this?
Yeah. So the symptoms that are clearly associated with polycystic ovary that can be recognized is irregular menstrual cycles, and not in the first few years after puberty and after menarche, because during those years cycle abnormalities are very common. Irregular and infrequent bleeding, oligomenorrhea, as we say. So, but if this persists, let's say after the age of 18 to 20 years, then that would be suspicious for this diagnosis. Although there are other reasons for this, but at least this will be a sign that needs to give you the idea, or this needs to be figured out what is, and particularly if this coincides with signs of elevated androgen exposure, which is the male hormone, which all women have male hormones, like all men have female hormones. But if it's elevated in women, this may give rise to signs like hirsutism, so more male hair patterns, usually in your face, but it could also be in your body. So particularly if those two signs coincide, irregular periods, infrequent periods, and signs of increased hair growth, that should ring a bell.
Okay, so if we look at the short-term concerns and long-term concerns for women who have this syndrome, what is it as a patient that we need to be aware of?
Yeah, in terms of short-term concerns, now, let me go one step back. I think number one, there's no reason for panic, because this is a very common condition.
Okay.
To some extent, yeah, that may be reassuring. It's self-limiting in the proportion of women. It is also a condition that may not see any doctor referrals at all, but at short term, what is the clinical problem most frequently are 3 irregular menstrual periods.
Right.
Number one. Number two, increased extent of hair growth, as we mentioned. And number three, infertility. So if you try to get pregnant and if you have irregular periods or no periods, of course, that is probably not going to work, because these irregular or absent periods are a sign of ovulatory dysfunction. And if your ovary does not work normally, your chances to get pregnant without medical intervention are significantly reduced.
So that would be relatively within the reproductive years, things that women need to be told about. But as we move along in our lifespan after the reproductive years, is there anything else that this may lead to in the future that I need to be aware of?
Yeah, in women diagnosed with this condition, although it's not part of the diagnostic criteria,
Right.
a significant proportion of these women, they present with obesity, number one, and signs of insulin resistance and subtle metabolic dysfunction. That means that your metabolism is not working properly, including your insulin, your glucose and insulin balance. And these are, they may occur in the general population, but these are more prevalent in women diagnosed with PCOS, and they may have implications for pregnancy and children outcomes, but it may also have implications for later life health risks in these women.
So I think what we're also talking about then is our blood sugars, our blood cholesterols, our triglycerides. So in terms of lifestyle management, before we talk about seeing a healthcare practitioner who might offer me medical strategies or medications, what's important for us to be able to do to decrease the long-term healthcare risks in terms of a lifestyle?
Yeah. I think a very relevant question. You can clearly see there are also differences between the way patients are managed in the US versus Europe. For all individuals, men and women, but of course, particularly for women at risk, lifestyle management is a key factor, is very, very important. That means trying to reduce weight in overweight women. And that doesn't mean that you have to go through the frustration to normalize body weight, but even a modest decrease in body weight, 5 to 10%, has been shown to have clear advantages in terms of metabolic dysfunction, even in terms of chances to get pregnant, either without medical intervention or with medical intervention. So those are the things you can do: lifestyle, physical activities, healthy sleep, decrease overweight, body weight. These are very general measures for the general population, but they certainly more frequently apply to women diagnosed with PCOS.
And from a medical perspective, once we try to make lifestyle changes, and we know how difficult it is in the long term to adapt these healthy lifestyle and then maintain the healthy lifestyles, is there something that a doctor, a nurse practitioner, your healthcare practitioner might offer you in terms of therapies?
Yes, so there is a lot of potential medication or medication which is potentially useful, but also I think we have to be very careful for overuse without the proper evidence. I know that particularly in the US, there are women put on multi-medication from a young age onwards for decades. And we have to acknowledge that there's no proof of its benefits. And these may, appetite-lowering drugs, these may represent insulin sensitizers. There are various forms of this. Now there's a whole range of new drugs focused on the leptin system. So there is many, many drugs. But believe me, when you ask me what is the evidence that this is efficacious in women diagnosed with polycystic ovary syndrome to reduce long-term health risk, to be honest, I think there is no evidence as yet. And of course, this is in general, when you need to do a 30-year follow-up study, that is not going to be easy to deliver the message and the evidence. On the other hand, I think we have to be careful with too much medication too early, because it also gives the wrong message that medication can take care of the problems. It is not that simple, and still the key in reducing long-term health risk, I think, is the behavior of women themselves, and we should put all efforts in supporting that, although we all realize how hard it is.
Very hard. And before I let you go, for women who are watching who may have PCOS and are going through the fertility years and are successful in having children, are there any implications that we need to worry about for our children, either in terms of inheriting this condition or them being at risk for future disease, whether they're boy or girls? what is it that we as a woman who has PCOS, who ultimately does have children, need to be concerned about?
Yeah, a very relevant question, and I think very pertinent for women to understand. There is, at least in our area of medicine, there's a new area developing, which is called periconception health. That means health of women before or around they get pregnant. And this is beyond PCOS, but I think it's particularly relevant for PCOS. But this is, when you think about the embryo and embryo development, it is easy to imagine that what happens during the embryo, during pregnancy, has implications for later life health. And now there's a whole new science in this area. So earliest phases of embryonic development is clearly determining later life health risks. Believe it or not, but there are many, many studies to show this. So for PCOS, if you talk about obesity in line or in combination with metabolic dysfunction and in combination with insulin resistance, you can easily understand that the health of a woman like that before she gets pregnant is not optimal. And you can easily understand that if a woman under those conditions does get pregnant, there are increased chances for pregnancy complications, particularly gestational diabetes, so developing of diabetes during pregnancy, and preeclampsia, which is increased blood pressure during pregnancy. And those two factors during pregnancy are clearly associated with suboptimal children outcomes. Birth is a little earlier. Body weight of the child born is abnormal, but later on, and already during early childhood, you can see subtle metabolic abnormalities. They don't have the signs of that yet. They don't have symptoms,
Yes.
but when you look more carefully in a study environment, you already at a young age see clear abnormalities, both in female and male offspring, so both in boys and girls. And we have to, of course, again, study carefully what this means for the future. But overall, of course, I think it is fair to say that when you see subtle metabolic abnormalities at a young age, for sure, these individuals, these children, will have increased health risks later in life.
Well, it's a fascinating topic and one that clearly needs more research and more education about. And I thank you on behalf of our women listeners who have been watching to have educated us. And we look forward to more research as time goes forward. Thank you.
Thank you.